Hi everyone, in this video we are going to discuss about postoperative hypoxia and its management. I am Julian K. Thomas, faculty working in M College of Nursing. The objectives of this discussion include the group should be able to define hypoxia, enlist the causes and risk factors of hypoxia, list down the signs and symptoms of hypoxia, brief the diagnostic findings of hypoxia, and enumerate the management of hypoxia. Hypoxia. Hypoxia is a condition in which there is decreased oxygen to the tissue level. So anoxia is also a similar term where there is no oxygen left in the tissues. So hypoxia and hypoxemia are similar words, but it is not the same. So hypoxemia is defined when there is a decreased oxygenation to the tissues, and hypoxemia is defined as when there is a decreased oxygen in the blood. So this hypoxia can be generally classified into two, that is generalized hypoxia and regional hypoxia. So what is generalized hypoxia? When there is a decreased oxygenation to the tissues throughout the body, then we can say it is a generalized hypoxia. And when there is a region of the body which is lacking oxygen, then we can say it is a regional hypoxia. So a pathological condition in which the body as a whole deprives of oxygen, then we can say it's a generalized hypoxia, or a region of the body deprives of oxygen, then we can say it is a regional hypoxia. So if a lack of oxygen exists for longer than 3 to 4 minutes, so there will be irreversible brain damage can happen to the patient. So it is very important to treat hypoxia as early as possible to prevent complications. Hypoxia is a medical emergency and it should be treated promptly. One should identify hypoxia at the earliest and prompt treatment should be provided for the patient. So failure to initiate oxygen therapy can result in serious harm to the patient. The essence of oxygen therapy is to provide oxygen according to target saturation rate and to monitor the saturation rate to keep it within the target range. So the normal saturation level for a normal adult is 92 to 98%, or for patients with COPD, chronic obstructive pulmonary disease, the target saturation ranges from 88 to 92%. Postoperative hypoxia. So how we can define a postoperative hypoxia? So early postoperative hypoxemia is defined as the pulse oximetry reading of SpO2 less than 90% lasting for at least 30 seconds during the transportation of patient from operating theater to the recovery room, and the patient will recover within 20 minutes postoperatively. So while we are shifting a patient from operation theater to the recovery room, if the patient's saturation drops less than 90%, at least for 30 seconds, but the patient recover within 20 minutes postoperatively. So then we can say it is postoperative hypoxia. What is the acceptable arterial oxygen tension in the room air? So for an adult and child, the normal partial pressure of oxygen should be 97 and the saturation should be 97. So what is the acceptable range for a normal adult and a child is more than partial pressure of oxygen should be more than 80 and the saturation should be more than 95. So this hypoxemia again we can classify into mild, moderate and the severe based upon the amount of the saturation. So if we say hypoxemia it is mild, then the PaO2 should be 60 and the saturation should be 90%. And the hypoxemia should be classified under moderate, then the PaO2 will be 50 and the saturation will be 80%. And hypoxemia in case of severe, the PaO2 will be 40 and the saturation will be 70%. So this is the classification of hypoxemia based on the saturation level and the partial pressure of oxygen of the patient. Types of hypoxia. The types of hypoxia include hypoxic hypoxia, pulmonary hypoxia, anemic hypoxia, stagnant hypoxia, and cellular hypoxia. So, what is a hypoxic hypoxia? So, hypoxic hypoxia is a condition in which there will be less oxygen which is supplied to the tissue level. So, hypoxic hypoxemia can result from a low fraction of inspired oxygen or FiO2 or when there is a hypoventilation. So the oxygen or the air which we are taking has only a less amount of oxygen, then this hypoxic hypoxia can happen. Pulmonary hypoxia include pulmonary hypoxia happens as a result of any problems or disorders which is related to the pulmonary system or the respiratory system. Any part of the lungs is affected. Because of that, if there is a decreased oxygenation to the tissues, then it is known as a pulmonary hypoxia. Anemic hypoxia. So anemia is a condition where there is decreased hemoglobin in the blood. So what will happen when there is oxygen diluted with the blood? So what will happen? The oxygen will be carried to the tissues in the form of oxyhemoglobin. So when there is a decreased amount of hemoglobin in the blood, the oxygen carrying capacity will be decreased. So as a result, there will be decreased oxygenation to the tissue. So such kind of hypoxia is known as anemic hypoxia. So when there is a decreased HB, when there is a decreased hemoglobin to bind with the oxygen, as a result, there will be decreased oxygen reaching to the tissues. That condition is known as anemic hypoxia. The next one is stagnant hypoxia. Stagnant hypoxia in this, the inspired air will have adequate amount of oxygen and the oxygen has been delivered to the blood also, but there is some problem with the circulation. As a result, there is no adequate blood supply to the tissues. Because of the decreased blood supply to the tissues, there will be decreased oxygen reaching to the tissue level. So such kind of hypoxia is known as stagnant hypoxia. In stagnant hypoxia, adequate amount of oxygen is available, but the blood is unable to carry this oxygen to the tissues. So that is known as stagnant hypoxia. The other one is the cellular hypoxia. So here in cellular hypoxia, what is the problem is that the cells is unable to utilize the oxygen which is reaching to the tissues. There is adequate amount of oxygen. There is no problem with the circulation. But the problem is with the cells are unable to utilize the oxygen which is reaching to the tissues. So such type of hypoxia is known as cellular hypoxia. So these are the classifications of hypoxia. Hypoxia, pulmonary hypoxia, anemic hypoxia, stagnant hypoxia, and cellular hypoxia. Risk factors for hypoxia. The risk factors for hypoxia include, so the increased risks include heavy smoking, obesity, sleep apnea, severe asthma, COPD, chronic obstructive pulmonary disease as pre-PFT, which is a limited role. So heavy smoking, how it can lead to hypoxia. So smokers, we know there will be increased amount of carbon monoxide. So what will happen? The blood will contain increased amount of carbon monoxide. So this blood have decreased oxyhemoglobin. So the oxygenated hemoglobins are decreased. So there will be decreased oxygenation to the tissues. In obesity, what will happen? There will be adipose tissues dysfunction. Insulin resistance will be there for such kind of patients and there will be decreased oxygenation to the tissues. Sleep apnea. So what will happen in sleep apnea? There will be recurrent pause in the breathing. There will be intermittent hypoxemia for the patient and there will be hypercapnia, increased amount of carbon dioxide in the blood. So that is known as hypercapnia. So that will leads to decreased oxygen level in the tissues. So oxygen level drops in the tissue. In case of severe asthma, what will happen? There will be narrowing of the airway. So when there is a decreased space for the air to go in, when the airway narrows, there will be decreased oxygen to the lungs. Thereby, there is decreased oxygen to the tissues. So this is a clinical feature of asthma. So asthma patients will have hypoxia. So COPD, we know it is a chronic manifestations of the asthma in which there will be narrowed airways, so there will be decreased oxygenation to the tissues. All the alveoli will become fibrosed and the air is unable to get into the blood, so the patient will manifest with hypoxia. So pre-op PFT. So whenever the patient is going for the surgery, we will do a PFT and check how far the lungs is functioning. So if the PFT is values are decreased, so that patient has to undergo certain level of breathing exercises, coughing and breathing exercises to improve the lung functions and then only go for surgery. Otherwise, immediately after the surgery, the patient will manifest it with hypoxia. So the risk factors for hypoxemia can be classified into two, that is patient related risk factors and surgery related risk factors. So what are some of the risk factors from the patient side? So if the BMI is more than 30 kilogram per meter square, or if the patient is having obstructive sleep apnea, or the age of the patient is more than 65 years, or the ASA classification is for. ASA classification is American Society of Anesthesiologists. They have classified into four categories. That is the First category, that is the normal patient. Second category, patient with mild disease. And the third category is patient with severe systemic disease. And the fourth category is severe systemic disease with constant threat to the life. So that classification, if the patients comes under the classification of 4, they are at the risk for developing hypoxia postoperatively. Then moderate to severe cardiorespiratory disease, ineffective cough or poor lung function, pre-operative dependent living status or sepsis, or history of heavy smoking, that is more than 10 pack year. So pack year is nothing but how long the patient is taking cigarettes. So how to calculate the pack year is number of packs of cigarettes smoked per day multiplied with number of years smoked. These are the patient-related factors which can cause postoperative hypoxia. Then coming to surgery-related factors, what are the some of the surgical-related factors which can cause hypoxia postoperatively? For CABG patients, if the patient had a preoperative acute myocardial infarction or elevated free fatty acid concentrations, they are prone to develop postoperative hypoxia. For a TAAD surgery, that is a thoracic aortic aneurysm dissection, so the problem is with a large blood vessel, so which distribute blood from heart to the rest of the body. So in such cases, if the preoperative partial pressure of oxygen or FiO2 is less than or equal to 300 mm of Hg, or the patient had a long cardiac arrest time, or there will be massive blood transfusion, postoperatively more than 6 units of blood transfusion done within 24 hours, or loss of blood is more than 3000 ml. So such type categories of patients are at the risk of developing postoperative hypoxia. In case of thoracic surgery, the operating time is more than 80 minutes or the fluid balance during the operation exceed 4000 ml, they are prone to develop postoperative hypoxia. Coming to the abdominal surgery, including hepatectomy, upper or the upper and the lower abdominal incision is made for the patient, or multiple procedures in a single incision, or crystalloid replacement during operation is greater than 6 liters, or total operative time is more than 5 years, all these categories can lead to postoperative hypoxia. The causes of postoperative hypoxia includes inadequate post-op ventilation. If the patient is not getting adequate ventilation postoperatively, inadequate respiratory drive from the patient's side, increased airway resistance, decreased compliance. Compliance is nothing but the ability to stretch and expand. The lungs is unable to stretch and expand, that can lead to postoperative hypoxia. Neuromuscular or skeletal problems, increased dead space, increased carbon dioxide productions. The other causes include distribution of ventilation. Distribution of ventilation always depends upon the posture and configuration of the chest wall and the diaphragm. So if the chest wall and the diaphragm had some disability, so the distribution of ventilation is not adequate. Then distribution of perfusion, inadequate alveolar partial pressure of oxygen if the patient is anemic, perioperative aspirations, and inadequate pain relief. So pain and hypoxemia has a great correlation. So when there is a pain, there is a negative pressure in the blood vessels, so that can lead to hypovolemia and that can lead to hypoxia. So all these are some of the causes of postoperative hypoxia. So the other main reason for this postoperative hypoxia include, the first one is diffusion hypoxia. So what will happen? Diffusion hypoxia is mainly related to the anesthesia agent. So at the end of the anesthesia, after discontinuation of the nitrous oxide. So nitrous oxide is an important component of the anesthesia. So after the discontinuation of this nitrous oxide, what will happen? Immediately this nitrous oxide will diffuse from the blood into the alveoli much faster than the nitrogen diffuses from alveoli into the blood. So the nitrous oxide diffuses into the alveoli. So increased total volume of the gas in the alveoli. So that leads to fractional concentration of gases in the alveoli is diluted with the nitrous oxide. So which will leads to decreased partial pressure of oxygen and partial pressure of carbon dioxide, that can leads to hypoxia. So the alveoli will be diluted with the nitrous oxide from the anesthesia agent. So what will happen? There will be dilution happens and that can leads to hypoxia. So this usually occurs in the first 10 to 15 minutes of recovery. So therefore it is advised to use 100% of oxygen after discontinuation of anesthesia agents or the nitrous oxide. So immediately when we have removed the patient from the anesthesia, immediately the oxygen mask should be connected to the patient and make sure that 100% oxygen delivered to the patient to avoid diffusion hypoxia. The second one is prolonged effect of muscle relaxants. When we are giving muscle relaxants for the patients during the surgery, the diaphragm and the respiratory muscles will be relaxed. So what will happen? The patient will leads to hypoxia. And the third one is pain, which is a dominant factor in determining postoperative respiratory function. So which will promote atelectasis by restricting ventilatory excursions. And the fourth one is the pain relieving drugs, which is typified by the morphine. So which result in an increased incidence of respiratory complications not restricted to high doses which depresses ventilation. So morphine may reduce the reflex activity which provides for periodic hyperinflation. So pain which will have a very greater correlation with the hypoxia, where when we are administering pain relieving drugs for the patients, that will depresses the ventilation. It will depresses the CNS, so the ventilation will be depressed. So the patient will go into postoperative hypoxia. So what is the consequences or effect of postoperative hypoxia? So when a patient is manifested with postoperative hypoxia, so what is the effect on the CNS or the central nervous system? So when there is a hypoxia, there will be increased cerebral blood flow to the brain. So there will be increased intracranial pressure and there will be twitching and convulsion for the patient. So that can lead to brain edema leading to coma. Effects on cardiovascular system include there will be decreased cardiac output, so that the patient will manifest with arrhythmias. So when there is a decreased cardiac output, there will be increased heart rate and the blood pressure. So this can increases the risk for myocardial infarction, and there will be also increased productions of catecholamines that can also again leads to arrhythmias for the patient. The causative factors for the hypoxia can be classified under the mechanisms such as atelectasis, alveolar hypoventilation, impaired upper airway patency, and increased oxygen consumption. So all these mechanisms can lead to hypoxia. So how this atelectasis will happen? So atelectasis can be happened as a result of direct compression of the lungs during operation or incomplete lung re-expansion after the surgery, reduced chest wall and diaphragmatic movement due to surgical injury or pain can lead to atelectasis. So when there is a collapse of the alveoli or atelectasis, that can lead to hypoxia. And the second mechanism is the alveolar hypoventilation. So how this alveolar hypoventilation can happen? When there is a depressed level of consciousness due to residual effect of anesthetic agents or postoperative opioids. So when we are administering anesthetic agents or postoperative opioids, there can be a depression of the central nervous system. So there will be alveolar hypoventilation. So when there is a alveolar hypoventilation, that can lead to hypoxia. And the third mechanism is the impaired upper airway patency. So this can happen as a result of residual effect of the neuromuscular blocking agents or opioids or volatile anesthetics or other agents with sedative properties. So there will be airway tissue edema. So there will be decreased oxygenation to the airway. So impaired upper airway patency that can lead to hypoxia. The last one is the increased oxygen consumption. So during the surgery, if there is any inflammation or on the table the patient develops with shivering, fever or systemic inflammatory response, there will be increased oxygen consumption. So when our body needs increased oxygen, so it is unable to meet the level which what our body wants, so there will be increased oxygen consumptions. If the body is unable to meet this oxygen consumptions, that can lead to hypoxia. So these are some of the causative factors which can lead to hypoxia in the postoperative period. What are the signs and symptoms of hypoxia? So in the early phases, the signs and symptoms include restlessness, headache, confusion. There will be rapid heart rate or tachycardia, rapid breathing, tachypnea, anxiety, and difficulty in breathing. So these are the early signs and symptoms of hypoxia. And the severe symptoms of hypoxia include slow heart rate, extreme restlessness, and blue skin. That is known as the cyanosis. When there is a bluish discoloration of the skin, that is known as cyanosis. So these are the signs and symptoms of hypoxia in the severe state. So the signs and symptoms again, that is tachypnea, there will be increased respiration rate is an indication of respiratory distress. Dyspnea, there is shortness of breath is an indication of respiratory distress. The patient will use accessory muscle, the use of neck or intercostal muscles when the breathing is an indication of respiratory distress. The noisy breathing, that is audible noises with breathing or wheeze or crackles is an indication of respiratory condition. So always the nurse should assess the lung sounds for adventitious sound such as wheezing or crackles. Then secretions can plug the airway, it can obstruct the airway, so decreasing the amount of oxygen available for the gas exchange. So immediately we have to suction and remove the secretions which is present in the airway. And decreased oxygen saturation level is another signs and symptoms where the oxygen saturation will be less than 92% or between 92 to 98%. So patients with COPD, the oxygen saturation always we should maintain at a level of 88 to 92%. Lower than 88% is considered as hypoxic. The other signs and symptoms include flaring of the nostrils or pursed lip breathing. Patients who are hypoxic may breathe differently, which may signal the need for supplemental oxygen. Then the skin color of the patient, we have to check for the color of the skin. The changes in skin color to bluish or gray are a late sign of hypoxia. Position of the patient. So if the patient is having breathing difficulty, some of the patients may voluntarily sit up or lean forward or resting in the arms on their legs to enhance lung expansion. So patients who are hypoxic may not be able to lie flat, so that is a signs of respiratory distress. Then ability of patient to speak in full sentences. Patient in respiratory distress may be unable to speak in full sentences or may need to catch their breath in between the sentences. So late in mental status or loss of consciousness, this is a worsening and the late sign of hypoxia. And restlessness or anxiety, this is an early sign of hypoxia. So these are some of the signs and symptoms of hypoxia. The diagnosis of hypoxia include the early diagnosis of hypoxemia or hypoxia can be identified with the help of the pulse oximeter. So check the saturation of the patient using the pulse oximeter. So when we are shifting the patient from OT to the recovery room, the patient should be connected to a pulse oximeter continuously. So if the saturation is between 92 to 98%, it is acceptable level. If it goes beyond 92% or for COPD patients, if it goes beyond 88%, we need to take the actions. And the second one is continuous monitoring of the vital signs, the temperature, pulse, respiration and the blood pressure. Assess for anxiety, confusion and restlessness from the patient and check for the level of consciousness of the patient, whether the patient is unresponsive, arousable or awake. And check for any signs of cyanosis which manifest only when 15% or 2 to 3 grams of the hemoglobin is desaturated, then only the signs of cyanosis will happen. So cyanosis is a late sign of hypoxia. Check for the circulation of the patient, cool and clammy skin. Check for capillary refill. The regaining of the blood supply within less than 3 seconds is normal. So check for ABG and other monitors include oxygen analyzer, ABG, SVO2, then capnography, airway pressure monitor. So these are some of the other methods to identify hypoxia in the patient. The management of hypoxia, the first one is monitoring and the clinical assessment. So what clinical assessment and monitoring has to be done for the patient post-operatively? Check for altered mental status, disorientation and confusion or loss of consciousness or coma. So we need to assess the mental status of the patient postoperatively and check for any dyspnea or tachypnea for the patient. So whenever there is a respiratory distress, the carotid chemoreceptors are stimulated. So whenever the partial pressure of the oxygen falls below 50 mm of Hg, so the patient will manifest with the symptoms of dyspnea. Then cyanosis and cardiac arrhythmias, it is not readily detected in anemic or in an environment with poor ambient of the lighting. So cyanosis, as I said, it is a late signs of hypoxia because when there is 15% of the blood is desaturated, then only cyanosis can be expected. So this is a late sign of hypoxia and check for any cardiac arrhythmias for the patient. And other assessment which we can use in the management of hypoxia in the monitoring and the clinical assessment is the MUSE score. That is the modified early warning system. So whenever a patient condition is getting deteriorated, it can be easily assessed by using this score. That is known as modified early warning system or MUSE score. So which contains certain parameters like respiratory rate per minute, heart rate per minute, systolic blood pressure, consciousness level of the patient, then temperature and hourly urine output for the patient for 2 hours. So this all parameters will be assessed within a level of 3 to 3. So if the patient respiratory rate is less than 8, it will be noted under 2. It will be given as a rate of 2. If the patient respiratory rate is 9 to 14, that will be rated under the score of 0. If the respiratory rate of the patient is 15 to 20, it will be rated as 1. If the respiratory rate is 21 to 29, it is rated as 2. And if it is more than 30, it is rated at 3. So from a 3 to 3, it will be rated in the MUSE score. And heart rate also the same. So we have to calculate what is the score of the patient under this category. An early warning scoring system for detecting adult patients who are developing any critical illness. If the score of the patient is 1 to 2, perform second hourly observation and we should inform the nurse in charges. And if the score of the patient is 3, perform second hourly or hourly observations and we need to inform the in charges. Or if the mu score is more than 4, then immediately we have to inform the doctor who are on duty and perform observation at least half an hourly to ensure medical help for the patient. So the score should be always at 0. So the mu score when we are calculating, if it is 0, that is normal, or if starts from 1 to 2, then we have to inform the nurse in charges. So something is going wrong for the patient that we need to be assessed. The other management for hypoxia include oxygen therapy. So after major surgery, the patient should receive oxygen at least 72 hours at a concentration of 28 to 60%. Even if the patient is normal or if the patient oxygen saturation is normal, also we have to have a high flow oxygen for the patient at least for 48 to 72 hours. Urgent oxygen at 15 liters per minute using a non-rebreathing mask. Head tilt and chin lift or jaw thrust to open the airway. Suctioning of any blood or secretions. Then insertion of oropharyngeal airway for opening of the airway. Tracheal intubation and manual ventilation whenever there is an oxygen saturation drops. For pneumonia patients, we have to start on with antibiotics. Chest physiotherapy should be provided for the patient and bronchodilators. Postoperatively, if we are suspecting a pneumonia or the patient has been affected with pneumonia, immediately antibiotic treatment should be started. Chest physiotherapy should be provided for the patient and the patient should be started on with bronchodilators. So always consider any underlying causes for the hypoxia. So what is the causes we need to identify and that should be treated first, such as COPD, heart failure, or if the patient is anemic or the patient is having pneumonia. All these conditions to be treated first to avoid hypoxia. Then increase the FiO2 to 100%. Check the end tidal carbon dioxide and the peak airway pressure and auscultate the chest for the breath sounds and the check ET tube or circuit. Sometimes when there is a problem with the ET tube or the circuit also the patient will manifest with hypoxia. So first we need to check any mechanical problem, then only we have to go in detail for the patient. So first we need to assess the tubings and the machines first. If the patient is having airway obstructions, suction, then ABG analysis should be done. Think about re-intubation, ambu-bag, then adequate circulation. So always adequate postoperative fluid balance should be maintained for the patient for adequate cardiac output and adequate oxygen to the tissues. The nursing management for hypoxia include raise the head end of the bed, teach the patient deep breathing and coughing exercises, check the oxygen therapy and equipments needed for oxygen therapy, assess the need for bronchodilators. Oral suctioning should be done for the patient if there is any excessive secretions present for the patient. Pain relief, devices to enhance the secretion clearance, chest physiotherapy or handheld vibrator should be given for the patient. Then frequent rest in between the activities should be planned for the patient. So these are some of the nursing management for hypoxia. So to conclude, based on the findings, the oxygen supplementation should be given to all patients who have undergone general anesthesia both during the transfer from OT to the recovery room, and for at least 2 hours in the recovery room we should continue with the oxygen supplementation. And analyzing the arterial blood gas, calculating the alveolar or arterial oxygen gradient, determine whether administration of 100% oxygen leads to improvement. One can determine the specific type of hypoxemia which is particular to the patient. And leaving hypoxia untreated for prolonged periods leads to permanent organ injury, including brain death, and the patient will go into coma. So it is, as a nurse, it is very important to assess and identify the early signs of hypoxia, immediately get into the notice of the doctors and give adequate management as early as possible to prevent the complications. Thank you.